What is Horner's syndrome? Horner's syndrome is a combination of symptoms that arises when sympathetic trunk is damaged. The signs and symptoms occur on the same side ipsilateral. It is characterized by miosis, a constricted pupil, partial ptosis, a weak droopy eyelid, apparent anhidrosis, decreased sweating, with apparent enophthalmos, inset eyeball. A 65-year-old man with a history of hypertension is brought to the hospital due to sudden onset vertigo and dizziness that started an hour ago. On physical examination, there is ptosis and pupillary constriction in the left eye. Extraocular movements are normal in both eyes. Pain and temperature sensations are decreased over the left side of the face, and the direct corneal reflex is absent on the left. Pain and temperature are also decreased over the right side of the body. Muscle strength is 5 in all 4 extremities, with normal deep tendon reflexes. Which of the following is the most likely cause of this patient's asymmetrical pupils? The correct answer is E, impaired sympathetic activity. This patient, with acute vertigo, sensory loss, and abnormal eye findings, most likely suffered a stroke affecting the brainstem. The presence of unilateral ptosis and miosis indicates impaired sympathetic activity, that is Horner syndrome. Sympathetic innervation of the eye follows a complex pathway. First-order axons originate in the hypothalamus and descend in the lateral brainstem next to the spinothalamic tract. They exit the spinal cord at T1 and T2 to reach the paravertebral sympathetic chain. Second-order axons ascend to the superior cervical ganglion. Third-order axons then continue to ascend along the carotid artery via the carotid plexus. They then traverse the ciliary and oculomotor nerves to innervate the pupillary dilator muscle, dilates pupil, superior tarsal muscle, elevates upper lid. This patient also has a unilateral loss of the direct afferent corneal reflex, which is mediated by the ophthalmic nerve, cranial nerve 5, first branch. In combination with the loss of pain and temperature sensation on the same side of the face, these findings suggest damage to the ipsilateral spinal trigeminal nucleus in the lateral medulla. The patient's vertigo vestibular nucleus and contralateral loss of pain and temperature sensation of the body, spinothalamic tract, are further consistent with damage to the lateral medulla, that is, lateral medullary syndrome. Lateral medullary Wallenberg syndrome, vestibular nucleus, vertigo, diplopia, nystagmus, vomiting. Spinal trigeminal nucleus, ipsilateral facial loss of pain and temperature. Inferior cerebellar peduncle, ataxia. Nucleus ambiguous, diminished gag reflex, dysphagia, and dysphonia. Spinothalamic tract, contralateral loss of trunk and extremity pain and temperature sensation. Choice A. Abnormal neuromuscular junction function can result in myasthenia gravis, which often causes asymmetric fluctuating ptosis. However, patients with myasthenia gravis often have diplopia, the pupils are not affected, and they do not have sensation deficits. Choice B. The oculomotor nerve, cranial nerve 3, provides parasympathetic input to the iris and lens, and also regulates pupillary constriction. However, damage to parasympathetics would lead to abnormal pupillary dilation. In addition, because cranial nerve 3 provides motor innervation to most of the extraocular muscles, dysfunction would also lead to abnormal extraocular movements. Choice C. Compression of the trigeminal nerve, cranial nerve 5, could lead to impaired facial sensation and an absent corneal reflex due to interruption of the afferent sensory limb of the corneal reflex. However, it would not lead to ptosis or a constricted pupil. Choice D. A constricted pupil occurs in Horner syndrome because the normal parasympathetic activity is not balanced by the sympathetic activity. This relative overactivity of parasympathetics when compared to the activity of sympathetics leads to pupillary constriction. Decreased parasympathetic activity would be expected to cause a dilated pupil. Educational objective. A stroke in the lateral brainstem can lead to ipsilateral Horner syndrome because sympathetic neurons travel next to the spinothalamic tract in the lateral medulla.